Hi, this is Brianne for Sexuality and Occupational Therapy, and today we're going to be interviewing Erin Clark about disability and sexuality. Erin Clark is an award-winning nonfiction writer, Canadian world traveler, artist, and the current world champion para-pole dancer, world record holder in para-pole, and two-time Spanish national para-pole champion. Erin's work focuses on her body, connection and intimacy and progression of movement between locations and states of being. She centers herself in narratives where disability is often absent. Themes such as triumph, glamour, power, sex and romance, autonomy, and the intrepid by first pursuing those experiences in her real and personal life, and then expressing them in her art through text, self-portraits, and short film. Her work has been added to several university curriculums, and she is a frequent guest speaker on the topics of representation of disability, accessibility, and disability and sexuality. Welcome, Erin.
Thank you.
So why don't you tell me a little bit about yourself and your disability?
What specifically do you want to know about my disability?
I guess
what information
I know you were born with it, so a little bit about what your diagnosis is and maybe what the process was of sort of learning about it as you were growing with it.
Okay. I was born with a spinal defect, which is uncreatively called sacral agenesis, which is literally just Latin for spinal, like for sacrum not forming.
Very fancy name.
Yeah. Very creative. I think in some circles it's also referred to as a caudal regression, which is also literally the same. Like it's just, these are just literal names for what has occurred in the body. For me, it was discovered several days after I was born because I was not outputting urine, and I was getting sluggish. And when my mother took me to the local hospital, discovered just a general something's not quite right, but we lived in a small town in Northern Ontario, so they could not diagnose it. And they had me sent to the big children's hospital in Toronto. And this is 1981. So there they discovered a lump at the base of my spine, which they thought was maybe a tumor, causing a loss of function in my bladder. So they did a biopsy, and when they biopsied it, realized that they had actually just cut a chunk of my spinal cord.
Oh my.
Because because when the spinal cord forms, the bones are there first, and it comes down through the spinal column, and it gets to the tailbone, which is literally an arrow that is like this way, and I didn't have one. So the nerves just kind of curled into themselves. So some made it into my legs and some were just kind of there. And they had just cut a chunk of it out. And unlike a spinal cord injury in which the nerves have all gone where they were supposed to go, and then there's a break at a specific point that causes damage in a relatively predictable and organized manner from there down, I naturally was born with a disorganized nervous system. Like it was random which nerves had gone where. And now they had sort of cut out of a mass. So not out of like the cord as it should be, just a ball of, kind of like a bowl of spaghetti. And then they're like, this bit.
Yeah, so the paralysis, they don't know what they cut.
Exactly. So the paralysis has always been, it's from the waist down. That's the only like clear description. After that, it's all random. And so there are muscles that innervate, but not voluntarily. There are parts that I can feel, but I have voluntary movement. There are parts I have no sensation over at all. And they're right next to parts where I have normal sensation, or they trail into parts where I have altered sensation. Some of this shifts. So nerves they'll turn off and I'll be like, I don't know what's going on there. And then they'll come back later. And so there's what has been benefit, because you asked in terms of like coming, like as I grew up coming to know it, uh it's I have personally approached it as a like kind of anything's possible, you know, at any point anything is possible. And so I tend to put myself into different situations or movements in which I can learn how my body adapts to it, because it isn't knowledge that I necessarily have until I'm trying it. So the prognosis at that point was that, well, she's now more paralyzed than she was when she got here. Probably she won't walk. If she does, it'll be with crutches. Everything will happen at a very like delayed pace. And so I was put through the rehabilitative standards for children with similar disabilities. And the closest relative to sacral agenesis is spina bifida.
Okay, yeah.
So the clinics that those children were going through, I kind of piggybacked, although no one had heard of what I had. So it's not a direct parallel. I have no like shunting issues or like hydrocephalus, or there's a lot of the common symptoms of spina bifida do not occur in sacral agenesis at all. So yeah, there was a bit of massive uncertainty really in terms of how it would play out physically over the course of my life. And one of the major shifts was that I did walk with crutches and braces for quite a while. And then around puberty, the combination of just how this happens in anyone's body, and scoliosis is common in teenage girls.
Yeah.
But the combination of that and the fact that the way that I was compensating for the lack of deliberate muscle movement I've done this my whole life, I still do it now, was with momentum. If I can generate momentum, I use less physical effort.
Yes, that makes sense.
So I would use the crutches. I would put them in front of me and then swing my body through, and then the momentum coming through would sort of catapult me forward. And so then I was basically, in the same way that walking is literally controlled falling, that's what I was controlling. I was swinging through and then controlling the fall with my crutches. And they think that exacerbated the scoliosis to some extent. And also, if I wasn't using crutches at all, in order to make my legs lift up, I had to tilt my back bar backwards and sway, so that, again, I was generating a momentum, but it was my legs I was swinging through. So I ended up with a very severe scoliosis, like 105-degree curvature in 3 directions. So I was rotated this way, hunched forward, and curved like a C simultaneously. And my lung capacity was really restricted. I was in a lot of pain, and they were starting to find signs of like my organ function was decreasing. So they did a spinal fusion, but there was so much delay that by the time they got to the surgery, the lower part of my spine that they wanted to fuse to had gone through so much friction, it wasn't solid enough to fuse the metal into.
Yeah.
So they could only actually fuse a shorter amount of my spine, which meant that the fix was only about 75 degrees. However, it alleviated the pain. And then in the future, when I got into aerial arts and pole dancing, I was capable of doing those things because my hips weren't fused. So
yeah.
In the end ended up being kind of like unintentionally perfect, because it took away the pain and gave me a greater stability, but it didn't reduce my mobility as much as they had planned to. So after that, though, I couldn't sway to walk. I couldn't generate momentum. And so it was very, like, every step I took was 100% effort, which is just not the way my body wants to move. So I transitioned into a wheelchair full time at that point, which I loved because then I wasn't encased in plastic. Like my body was free, my skin was breathing. I was a 13-year-old girl and I wanted to just like feel my body. So I was into it. I had to really fight the the man like just the whole like medical complex was like against this, you know. For them it's a failure, like everything is a push to like be as normal as possible in how you function, and I was like, I'm fast on wheels, I'm happy. So, and also I was moving a lot more because I could go farther, I could go faster, I had more energy. And so even though I was in the chair, I wasn't sedentary because I would take the chair to go places and then get out of the chair and I was crawling and swinging and hanging. And so I ended up with a more physical lifestyle with the chair involved than I had if I had been fighting with crutches. But that's kind of that's the diagnosis. So sacral agenesis, and then I have partial paralysis from about L4 down.
Yeah.
Which the most significant impact aside from like muscle weakness, like atrophy and paralysis, is that I have a neurogenic bladder, which is probably the only symptom I would have had they not done the biopsy. Like that, my muscles would have probably developed normally without that. It might have been slow as my nerves kind of found other ways there.
Yeah.
But my legs did not seem affected until after the surgery. So that is that.
That's an interesting story to think about, you know, like the audience for the videos, they're going to be occupational therapists. And so it is a part of the medical profession. And it's always interesting. Occupational therapy talks a lot about like making sure that the goals are client centered. You know, like my goal might be for someone to put their socks on, but if their partner is going to do it or they're just never going to wear socks again, like then my goal doesn't matter. Like only what they want to do matters. And so like that's been a big part of like the occupational therapy push, is that like whatever we think the patient should be doing doesn't really matter if it's not important to them. And it ends up wasting their time, because if I spend, you know, treatment sessions trying to teach someone how to put their socks on and they don't want to do it, you know, you've wasted the time. So it's interesting to think about how they wanted you to walk so badly, but I
think it's not even just that it's a waste of time. It's also a very concentrated message that there's fundamentally something wrong with you, because not only did they want me to focus on walking, there was also, it was obvious that no matter how hard I trained to be able to walk, it was never going to be like other people. It was still never going to be enough. And it was, the motivation behind it wasn't for my benefit. It's easier on caretakers and it makes everyone else more comfortable. And so it isn't just wasting your time. It's also telling you that you don't count. What you want doesn't matter. What feels good to you is not valuable. You are an inconvenience, and your entire objective is to use all the energy that you have to make yourself as convenient as possible on other people. Like that was the message I got from it. I mean, the individual therapists, of course, are doing their best to be compassionate and to, you know, to connect. But the whole philosophy behind what they were doing at that time was very erasing. Yeah. So and because we're segueing into, you know, disability and sexuality, when you think of this in the context of children, so this is the beginning of my life. I have no identity yet. You know, I am not my own person yet. I'm not even, the idea of sexuality has not crossed anyone's minds yet. I started with a message that my body wasn't for me. Right from the very beginning, that was the platform. Other people got to touch it when they wanted to. They got to look at it when they wanted to. They got to make diagnoses about that. What's the word? When you predict what will happen in the future medically.
No, I can't think of
prognosis.
Yes.
When you are an oracle of the medicines. So there was a lot of these people had power. They had authority. It could be very shaming, even without the intention, because it was very much not like all the attention was focused on me, which I enjoyed, but I was not the driving motivation And
Yeah.
so the fact that I made that my motivation, and that my mother really supported like what I wanted to do, how I wanted to live. If I decided that I was going to be in a chair and not wear their like Dini back brace for like my entire grade 9 year, then that's what I got to make that call, and she wasn't going to fight me. But that was it was it took a lot to stand up to that, and to really understand where I was coming from in advocating for myself, and that I had to do it like against disapproving medical professionals while I was 13 and going through puberty. It was very intense.
An age when women are already having enough time, hard enough time, with body autonomy, it puts like a little extra on it.
Yeah, it was very intense. Yeah.
That kind of segued nice into sort of the next question, which is, now looking back, like, I follow your Instagram and I've seen a lot of things you posted about, sexuality and disability and that kind of stuff. Like, why do you think it's so important to sort of put that out there and talk about it now?
The thing that's on the top of my mind, particularly these days, largely because, I'm writing about how my early experiences still affect me to this day. And one of the, something that's really stood out to me is that because I had a neurogenic bladder, a lot of the medical procedures that I got as a child involved invasive procedures in my genitals. And as a child, because it wasn't painful, it wasn't really a big deal. But when I started to hit puberty and my body was coursing with hormones, having my genitals touched was arousing, involuntarily so.
Yeah.
And no one ever said to me anything about sex whatsoever, ever. Not that it was okay that I felt arousal, not that arousal was a thing for me that I was gonna, like there was no frame of reference whatsoever. All I knew was that there was something perversely wrong with me, that I would be having this experience and I didn't have anyone I could talk to. And on top of nobody going out of their way to say anything to me, whenever sex was being discussed in not disabled environments, so in school or in media, or there was the only time disability came up was when it was as a taboo. So I knew that anyone who wanted to have sex with me was a pervert. Probably I didn't even have the sexuality because that was gross and weird. Like, it's a very, disabled people are very desexualized, actively desexualized. It's not subtle, like people tell you that you are not a sexual person, that's not an experience for you. And nobody my age obviously has the maturity to handle the complexities of their own burgeoning sexuality, let alone this added layer of like, what does it mean to date or desire the disabled girl? So like, as I was going through the things everyone else was going through, there was also this extra layer of like, this whole experience of sexuality, of discovering my sexuality, of experiencing it, of interacting with other people in a sexual way is not for me. So I had all of these questions and nowhere to explore them that was safe, because the only people available to me to explore those things were people who very specifically had a fetish for disability. And so you could feel that it was not about you. It was not about it was so, and that would just confirm that when people had this idea that like anyone who wanted to have sex with me was obviously taking advantage of me, was confirmed by the fact that the people who were the most available were fetishists. So it was all just very like, okay, you know what? Sex is terrifying and dangerous. All that can ever happen is I'm going to get hurt. I am a sick fuck because every time a doctor touches my genitals, I get aroused. I'm just not going to deal with this. Like, it's not for me. I don't exist in this sphere. There's no place for me here. And even if I everywhere else in the world, in sort of life, I would feel the same way, but I would think, fuck it. I'm going there. I want that.
Yeah.
Sex was the one place where I was like, okay, no, you guys are right. It's not for me. I can't handle this. And I think, like, it would have made I even had my first period in a hospital. The surgery that I had for my spinal fusion was so stressful on my system that it triggered my first period. And still nobody talked to me about my body as a woman. They
Wow.
just brought me pads and told me I was menstruating. So I think just the slightest anything that gave me the idea that I had a body and therefore would have a sexuality, and that I would need to figure out for myself, like that was not just my like that it was my responsibility, as well as this feeling that I had, this weird feeling when like the intimacy that I was constantly being forced into with doctors, that it was right that I felt uncomfortable because I was protecting something precious. And if I think the first time that I had an exchange with a doctor where they kind of acknowledged that, I was well into my 30s, and I went to a urologist to get a where they fill your bladder up and see how much water it can hold. And before the doctor ever got a chance to talk to me, his staff had put me in a gown and inserted catheters, so that the first time we met, I was in this very compromised position because they couldn't figure out what they had done wrong with the equipment. And he went out of his way to apologize. He said, I don't like to meet my patients for the first time when they're like undressed and in mid procedure. You should have, like, I should have greeted you and had an interaction with you beforehand. And he wasn't saying like, you know, because this is like, he was acknowledging this, like this dignity that I deserved. And that's not something that happened very frequently for me, you know, in medical contexts. And because it's such an intimate thing, when that is your introduction to your body, it really can blur the boundaries and what privacy you have right to, what pleasure you have a right to, where the lines are. But and like you were saying, you know, even the shift from, as the professional, it's my job to tell you what your goals are, you know, versus as a professional, it's my job to help you meet your goals. I think for sure in the area of sexuality, that is, I think it's a really, really necessary conversation to come up, even in the smallest of ways. And I know I've had a couple of conversations with doctors who interact with patients after an accident, and so their body has changed dramatically, you know, from what they were used to. And in those situations, the thing that they're dealing with that never gets brought up is that all of the ableism that person had before the accident comes with them after and is now internalized. And because that whole societal projection that disabled people are undesirable and unsexual, now that's how they feel about themselves, but it's a shift. And
do you find, like, I feel like often too, like they don't realize it, like people don't realize their level of ableism until they're in a position where it's taken away. You know, I see that a lot when I work with patients and we're doing something and all of a sudden they're like, I never thought about the fact that it might be hard to brush my teeth or put on my socks. Like, I never thought about any of these things before, or like how I'd feel going somewhere with my walker or something like that. You know, they really don't think about it until they're already in that position.
Well, and often they'll be comfortable saying that to you, but they won't be comfortable saying, I don't think I'll ever have sex again because I'm like this now.
Yeah.
Like the patients are not initiating that conversation. They're just accepting that that's the reality now, because there's literally no evidence to the contrary. And the medical professionals have never, like, your doctor comes in and say you have a spinal cord injury, and you get all of this information about how you're going to poop and how you're going to pee and how you're going to transfer into and out of a chair and how you're going to pick up a pen, or how, you know, like there's this massive amount of rehabilitation. And I had a friend who was also an aerialist, and then that was the cause of her spinal injury. And she asked me if I knew anything about I think it's called a mitral fan-off, which is where they reroute the bladder through the belly button.
Okay.
And it makes catheterizing really easy because you don't have to transfer to a toilet. It's just through your belly button. She asked me what I thought about it. And I said, I think if transferring is like a massive issue, it sounds like a really liberating procedure. But my belly button is an erogenous zone for me. And so I would think really long and hard about whether or not I wanted to make that trade off. And she said, I haven't thought about what my erogenous zones are now. Never even crossed her mind. It never came up. And, and I thought, well, yeah, you're going to need to know that.
Yeah.
It's an important conversation to be having with herself. But if someone had suggested it to her in rehab, she might have had it years earlier.
Yeah, I think it goes back, like that's a lot of sort of why I've even started doing this project. So, occupational therapy, they're who sort of work with people in the rehab complex on the toileting and the bathing and the dressing and all that. And technically sexuality falls within their domain, but it's sort of like we talked about with sort of imposing the goals on people. I think when people are in rehab, we have the tendency to think like, well, getting dressed is more important than having sex. But realistically, sex is an important part of who we are as people, how we express ourselves, how we seek pleasure, and how we get to know our bodies. And so, we're trying to get away from sort of creating a hierarchy of what's most important that we do in our day, let's say. But it's still something that I think, we're constantly fighting against. And it is hard because you're taking a patient who's in a super vulnerable position and is just trying to manage all the handouts and home exercise programs and instructions being thrown at them, to then ask them to sort of have the courage to talk about sex when their therapist can't even get the courage to bring it up. It becomes like a very sort of weird situation. And I've read like a lot of articles, even from patients, often stroke or spinal cord injury patients, who say that, like, I wish I had asked someone, but no one ever opened the door. And like, it's so vulnerable that they don't want to ask and then have someone reject it, and so it becomes like a very sensitive subject.
Well, and I think part of what makes it really important, especially when you think about injuries, is that there's so much rejection of the body going through that procedure. There's so much, this innate feeling of inferiority now, of like a lowered like life satisfaction, like the depression that's being fought, and like, what hope do I have, what can I look forward to, like a lot of this I've lost my sense of myself. Who am I? Huge existential questions that are very much centered around the body. Like who you are has not actually changed at all. This intense identification with a perfectly working body is really in a way, I think of that as the reverse disability that like able-bodied people have, like just like how intensely identified they are with how their body functions, so that if it changes, they're at a complete loss for any kind of connection with themselves, even though they're still inside themselves. They haven't gone anywhere.
Yeah.
And I think that one of the ways that we communicate with ourselves is through pleasure. It's one of the reasons why it's such a devastating loss. What will please me ever again? What will feel good? What will feel easy? How will I connect? How will people access me? How will they get to me? I know I'm in here, but how will other people know I'm still in here? They'll see the chair, they'll see the walker, they won't. And those are the questions that I think are like why discussing and exploring sexuality becomes really important therapeutically, because it's a way of reconnecting with yourself and how you're going to connect with other people, so that it isn't this like black, dark pit of unknowing, like of unknowable things, that you don't have to have every answer, because it's like any other relationship, you figure it out as you go. But it has to start with, you can't access pleasure without there being a certain amount of acceptance. You have to be present with yourself where you're at. Intimacy is built with attention and like it's with detail. and so building that relationship with yourself, I think, helps to resolve a lot of the deeper and very like intense emotional and psychological crisis of a transition like that.
Yeah. I mean, you've answered a lot of the questions I was going to ask, but one thing that I do in this, which is great, this is great. One of the questions I do want to ask is, and you mentioned a couple, the idea that, anyone who'd be interested in someone with a disability is a pervert, or people who have a disability are not sexual. Like, are there any big stereotypes that you think, really do affect that process? So like one thing I was thinking about, even when you were speaking, is a lot of times when I have patients, they never want to look in the mirror. And like, it is sort of what you're saying, like a disconnect. Like if they don't acknowledge it, then it's not happening. And it sort of does set them up for the feeling of like, oh, now my new body can't do this and can't do that and can't do this thing. And that's really not true. They could really do almost anything they did before. It's not going to be exactly the same, but that doesn't mean it's not going to be good too.
Yeah.
And so I wonder if you could speak a little bit to like the stereotypes, maybe any others that you've encountered, or sort of how you overcome them without much guidance. Because you've talked a lot about how you didn't really get much education. You haven't had like a ton of, not that you haven't had support, but you haven't had support on this one subject, like someone who could speak to it with wisdom, let's say.
I don't know if this answers your question, but this is what it made me think of, that I start with the benefit of being a naturally sensually oriented person. I crave sensations, and I'm affected by sensations. I also didn't have to adjust to this body. It's the one that I came with. And I've always experienced a very deep pleasure being in this body. That is a natural thing. And so when I encountered the stigmas and the stereotypes other people had of what my being in my body was like, it was always effortlessly absurd to me. Like it just didn't match what I was experiencing at all. So I always had this bit of a space that made it easy for me to think they're probably wrong. Like probably what I'm feeling is more true, more reliable than how they see it. It doesn't mean it didn't affect me, but it there was just always a bit of a distance, like I get frequent condolences on my existence from strangers, like, oh, I'm so sorry. Oh, like where their sympathy is expressed in openly in pity, unsolicited from me. Often in moments when I am enjoying the effort of my muscles to push my chair, or my hair blowing in the breeze, or like in a moment when I am experiencing some exquisite sensual pleasure in my body, some stranger will come and apologize to me for my existence, like
Yeah.
so like the dissonance has always, it's been very clear to me that it has always been their problem, which isn't something somebody experiencing an injury will have. They won't have that distance. They won't have that buffer, because they'll have often been the one on the other side of it.
Yeah,
At
that's
least
very
thinking
true.
that condolence for someone else, and now here it's them, and they don't have any way of imagining. And to me, I think of that as a pity I feel in reverse, because if they're apologizing to me, chances are good that they have never experienced the level of pleasure I feel in my own body in their own perfect bodies. And that is sad. So
Yeah.
what are these people doing with their perfectly able bodies? Like clearly not enjoying them.
Yeah, no, that's
Because
very true.
so I think that there's a disconnect, period. Disability didn't cause it. Something else in society did. And then they just take it with them into their experience of disability. And now it's harder to get out, because the pleasures that they were experiencing before came only because of their privilege. They just came easily. They didn't have to work for it. They didn't have to sacrifice. They didn't have to take any risks, certainly not the risk of any kind of intimacy. So really, when disability is introduced into already something that wasn't working that well, what is being asked of them is an intimacy they have never before known. Not really a limit that they didn't know, or it's an invitation into something deeper than they had before. And that's terrifying for all of us, right? Like,
Yeah.
we are all terrified of intimacy, emotional, sexual, whatever. We don't want it. Keep it away. And disability, because of its innate vulnerability, is a constant invitation into intimacy, either with yourself, with your environment, with your equipment, or with other people. And when you don't know that you get to orchestrate that you get to set the boundaries, that you get to be part of the invitation, it isn't just thrust on you. This is a conversation and a dance you're participating in. Then it feels like an assault. It makes you feel helpless. It feels patronizing. It's almost entirely awful. So the next reasonable thing to do is to just shut down all intimacy, including with yourself. So yeah, you don't want to look in the mirror. You don't want to deal with your equipment. You don't, like, all of these change. Everything is just a reminder that this vulnerability has put you in a position of now being responsible for a relatively great, deep intimacy.
Yeah.
So I think it's so much, like, you can do this on the surface and just say, learn what your erogenous zones are. Like, there are practical, applications to address this. But I think it's really, what's actually happening is a much deeper psycho-spiritual, like, transition that they could have spent their entire life avoiding.
Yeah.
If it had just been easier. And now they can't. Now you, in order to access that pleasure or that connection, you have to acknowledge the vulnerability, or you can't get there. So it's really like, the facilitation from these medical professionals is really about helping us navigate that vulnerability in a way that makes us feel empowered and like we're participating in it, and learning about ourselves in a way that brings us more pleasure and brings us more autonomy and brings us more of a sense of creating it for ourselves, as opposed to it being prescribed to us, and our only power being able to just block it out. Like, that the only way we have left to assert ourselves is to just go, no,
Yeah.
leave me alone. Like, I'll learn how to bathe, but I don't want to fucking look at what's going on under the water.
Yeah, no, that makes sense. And actually sort of brings me a little bit into what my last question was going to be is, what do you think it's important for medical professionals to know or say or do when addressing sexuality with persons with disabilities? Because often we don't address it with, sex is a taboo subject, sadly, across the board.
Yeah.
Able-bodied people don't want to talk about it. Nobody really wants to talk about it. And so when you're dealing with it in a sensitive situation where someone's already dealing with what you're talking about, like having to overcome their own issues of intimacy that before they maybe just sort of skated by on, do you have any recommendations for the medical complex?
In terms of what they should, well, I would say that's a good question.
Maybe in terms
my
of
solution to the problem has been like because for me, part of the difficulty here is that I'm already medicalized enough. My entire relationship with my body is medicalized, and sex is the one thing that doesn't, when it's clinical, it isn't. Like, I spent so much of my 20s 30s with a very, like, approaching sex the way I approached physiotherapy, like, very clinically. I knew how to get to the orgasm, but there was no poetry, there was no connection, because that was how I knew how to interact with my body. And so there's a bit of a, like a catch-22 there, because if you never bring it up, then the idea that, like, how do we learn how to have safe sex or good sex, but if you do bring it up, then there's the risk of it just being another medicalized aspect of that person's experience. And so my personal solution has been to create sexy art. Like, like, I write and I take portraits, and I'm creating narratives that include sexuality that are sexy to read. so that the experience is one of sensuality and of connection and of intimacy emotionally there, but it isn't um, clinical. The choreography of it is what matters more, the feel of it, the sense of connection. But I think, that, so I would say in that case, try to familiarize yourself with art, narrative, stories being told by disabled people about their sexuality and their sexual experiences, so that you have resources to pass on that are not clinical.
Yeah, no, that
And that
makes
are
perfect
not
sense.
projections, that are not, because the only, like, guaranteed by the time, a client gets to you, they've seen all of the horrible movies in which the most noble thing a disabled person can do in a romantic story is kill themselves so that they don't burden their partner, right? Like, they've
Yeah,
seen
that's
all
a
of that
lot of
bullshit.
movie themes,
That's pretty much
sadly.
every movie. Yeah. So if like, of places where they can experience disability in the context of romance or sex, where they don't kill themselves in the end, that can help them start at least an internal, dialogue. If not, like, here are some sex toys that work for different disabilities. Because there's also a lot of that, right? Like, there are store companies that have created sex toys that facilitate different disabilities in terms of like what positions work, and like, if you've got like um, vibrators for reduced hand control, those resources are certainly out there, and just having those in your brain or in a, like a handout, or something like that, so that you can say, like, so by the way, while you're like buying this shower seat so that you can, like, safely shower, there's also these other resources. If you're interested, if you want to talk about it, let me know. And then that door has been opened, and it's okay now to talk about sex in the context of, occupational therapy.
Yeah. Yeah, no, I think that's a great idea. I think a lot, one important thing too that you really said is, to take it outside of sort of just being like so cut and dry and becoming very clinical. Because anytime I've seen sex addressed at this, like through this point from other people, and when I learned about it as a student, it was always like, oh, this person had a hip replacement. Here's the packet on how to have sex. You know what I mean? It's so cut and dry. Like, here are 4 stick figures. Here are the 4 positions you can do. Have a good day. Good luck. Nothing about like, hey, you might experience this, or you might experience that, or you might feel this way about the fact that, like, maybe these are 4 positions you don't want to have sex in, or you've never had sex
Right.
in. But, like,
Or,
we're not going to address that because here are the 4 that we gave you, so good luck. Like, there
yeah.
hasn't been a lot of looking outside of, like, it's not a clinical thing. It's not like putting your socks on, it's not step 1, step 2, step 3. It's a lot
I
more.
think if you keep in mind, regardless of how you actually put this into practice, but if you keep in mind that the reason why the idea that you can't have sex anymore hurts so badly is because of how every single human being needs to be able to feel connected. Like, that this is about, will I ever feel loved and connected again? It's a fundamental human need. We're hardwired for it. The mechanics of sex are solvable in almost every case. People will figure out how to fuck. They're animals. They'll figure it out. But if they don't believe that they deserve it, or that it's possible to connect again, that's really what they're struggling with. Like, any occupational therapist can help, a client figure out what positions their body can be in to receive pleasure, right? Like, the mechanics of it are not the hard
Yeah.
part. It's the underlying sense that this is no longer for me, and it can never happen, that makes it so important to bring up.
Yeah. Yeah, no, that's great. Any last thoughts before I sort of this is amazing. You touched on, first of all the questions I didn't even have to ask them, so that's made my life really easy. But
Excellent.
also, you touched on some stuff that I hadn't even thought of, which is sort of why I wanted to do, a series of interviews, because I do approach it from a different perspective. I'm approaching it from the medical complex perspective. And as much as I try to step out of it, I can't, I, at this point, can't change the background I've come from. I can only change what I look at going forward, which is sort of how I found, like, you on the internet and quite a few other people, is because I started thinking about, like, I don't think we're doing this right. And
Well,
like,
I would say that, yeah, that would be my final thought, is what you're doing is what people should be doing. Ask disabled people.
yeah. Yeah, no, because you don't want to speak for someone else. Like I can speak from the medical perspective of like, here's what our job does, and here's how we can integrate the things that you're saying into our profession, because that's the idea that I come from. But I can't speak to what someone else feels. And like that's a lot of our profession, is remembering that. Like we can tell someone like, oh yeah, I kind of understand, but like, do I understand? Like, no, I have no idea what it would be like to have a stroke. Like I understand medically what's happened to you and the physiological experiences that you're having, and I can understand the emotions that you're telling me you express, but on a visceral level, can I really understand? No, like I can't. Like, and so it's important to, make sure that, like I said at the beginning, like that the patient or the client is the center of whatever we're doing, that they're the ones the driving force, and that we're acknowledging that they really know the most, like you've been saying the whole time, you know the most about your body.
Yeah. And if they don't in the moment when you meet them, they will become that expert in the course of your relationship together. Like that
Yeah.
should be the goal, is that they become more and more the expert of their own body.
Yeah.
And for, even something as simple as like on an intake form, having a box where you can check off sex as a topic you're interested in learning more about. Like I don't know how your sessions work, but like generally you have to fill in forms with your medical history, right? Or like, what
Yeah.
is the reason for your appointment today? Like, making it as easy as possible for them to indicate that that's something that they would like to discuss.
Yeah. No, I think that's great advice. So I guess the last thing I wanted to do is, I figured if you kind of wanted to tell people where they could find you, if they wanted to follow you on Instagram or, anything.
Yeah,
like
I'm on Instagram at Erin Unleashes.
that. Okay.
And that's pretty
Yeah.
much, I mean, everything is there. So that's
Well, I
one-stop shop.
recommend that people follow you, and I'll have a little thing at the bottom of the video with your Instagram as well, because I also know you're writing a book. So I would encourage people to also read that. I mean,
Yes.
that always helps to learn some more. But I really thank you for the interview.
Thank you so much. I really appreciate that you are doing this and bringing this topic out and putting it out there for people to learn from and think about. That's really cool.